Welcome back. I'm Barbara McGinnis, and this is the Takacs McGinnis Elder Care Law News Hour. And today we've been talking about advanced care planning and end-of-life decision making.
Hi, and I'm Tim Takacs, and in this segment we're going to continue exploring the physician's perspective on advanced care planning and end-of-life decision making from Dr. Chet Gentry. And welcome back, Dr. Gentry, and welcome Barbara Brennan. Barbara is a registered nurse who happens to lead one of Nashville's largest hospice organizations. Here to give us that perspective is Barbara Brennan, and welcome, Barbara, if I may call you Barbara.
Absolutely.
And so if we say Barbara,
we'll both
reply.
Yeah.
And Barbara Brennan is the Chief Operating Officer and Chief Nursing Officer at Alive Hospice in Nashville. I want to start by asking you a few questions that we posed to Dr. Gentry earlier. What is advanced care planning and how does it differ from end-of-life decision making?
Well, we view advanced care planning as part of normal planning that you do in life. Just as you make a decision about college or work or your will or marriage, we believe that advanced planning should be a normal part of life, so that it's not when you're facing end of life, it's well before that, because it's just a matter of expressing your desires, how you define quality of life, and what you want for when perhaps you're unable to make decisions for yourself. So it's really a plan like many others that you have in your life.
Mm-hmm. With a popular perception, I think, why don't you tell us a little bit about what hospice is before we kind of go further into this? Hospice, I mean, from our view, or at least from the elder law attorney's view, is that what people get in the last 2 or 3 days of their life, and that doesn't seem to be really, you know, an accurate definition of hospice.
That's correct. Hospice really provides care as someone at the end of their life, and usually in the last months of life. And we find that we can be most effective in surrounding people during that journey when we have them referred to us and we accept them in our care months before they die. And advanced planning really should precede that by years. Just as Dr. Gentry said, it's part of a normal physical. We believe it's part of other parts of planning too. So you may have a conversation over dinner, or you're starting to hear about how people enjoy their life, how they want to be at home, how they talk about others that they see that may be going back and forth to the hospital a lot, and you're starting already to understand what that individual's definition of quality of life is and how they want that to look for them. So there's lots of pieces along the way. And just as Dr. Gentry said, it's important to have a conversation with your physician, but it's even more important to have a conversation with your family and with your loved one. And as you select someone to speak for you when you may be unable to, hopefully you've had a series of conversations and experiences in life so they truly know what you want and where your decisions might lie.
Well, that sounds like the optimal arrangement, or when people come into you and they're in hospice and maybe they've already had that conversation. Mm-hmm. Is that really what you see out there in real life?
Sometimes.
Sometimes.
Sometimes. Many times people come in and they haven't had that conversation, and that really creates a lot of issues, not only in planning their care, but also when they become unable or they're not sure what they want to do. It can exacerbate conflict that's already there in a family, or dysfunction that's already there. So it creates real barriers for us in hospice. But one of the things that we're very proud of is that we've worked with families so much that we can help them work through that. So building the relationship with the hospice team and having very frank conversations throughout the process allows you to get to what the person really wants when they're decisional, and always focusing on the patient and what they want, not what the different family members who jump in at the last moment or arrive from somewhere out of state. So those pre-discussions really smooth over some of those things so you can focus on the individual during their end of life.
Because a lot of what we encounter is that either the client, the elder, will come in and say, I don't want to talk about that, or I don't need to talk about that. My kids know what I want. And then lo and behold, they're going to name all 5 of their children as their decision-making agent. Speak to that, the challenges you would have with managing care, but each of you.
Well, I think it is a challenge when you have different people who may have different opinions, and so hopefully they've listened to their loved one over time to have an idea of how they're defining quality of life, which will help them in their decision making. And when we find this dysfunction, it creates a lot of issues for our staff to stay focused on caring for their loved one. So usually that's the conversation we have, that it's a process over time and over many visits and over the stay of them in our care, of how they're evolving, how their disease is progressing, what their quality of life is, and when the dysfunction really gets emotional and there's arguing, that sort of thing, we just try to steer everyone back to let's take care of your mom in the best way possible. And when you do that, it helps them get over the fight between the brother and sister and then say, it is about mom, it's not about us.
I think one of the most, some of the important things to keep families focused on is to, first of all, remind the patient that they probably already know what they want. We just need to lay out the scenario as we expect it, and that gives them a little bit of relief from the anxiety about making the wrong decision, and to emphasize to the patient that it's really important that they be clear about what they want so that they don't put their family in a position of having to decide, and then to remind the family that their job is to support what the patient wants rather than to figure out what they want for their mom or dad.
Right.
Does this always work? I mean,
no, it doesn't always work.
Okay.
And so I think
Can you tell us a little bit about how maybe it doesn't work, and then what your options there are, or what your solutions might be for families and patients then?
Well, if someone doesn't have anything in writing, it really is a challenge sometimes. Yeah. And so we may look to our ethicist if we want to go that route, or work within our team about how do we determine is the best person to make the decisions. That when we look at these conflicts amongst our patient population, one of the biggest concerns is who is the surrogate decision maker when there hasn't been someone designated or when there's conflict. And so we would actually go back to legally what that might be, but our goal is always to try to breed consensus with the family so that this whole experience can be one of a normal part of life and a comfortable, peaceful death with consensus.
We're talking to Dr. Chet Gentry, hospice physician or palliative care physician, geriatrics, and Barbara Brennan from Alive Hospice. You mentioned about surrogate decision making, and of course that gets right into our wheelhouse as elder law attorneys about how do you decide who the surrogate decision maker is, healthcare decision maker is. Legally, we know several years ago the state allowed physicians and providers to choose somebody, and if there is nobody that can make a healthcare decision. So what are you looking for when you're trying to figure out who the right person is? Either one of you.
Looking for who will be the best advocate for the patient for what they want. And so sometimes when I'm asking a patient when we're doing advanced planning to pick the person, it may not necessarily be the closest relative. They may have difficulty making the decision that the patient wants, but the person who's going to be most likely to carry out their wishes.
And one of the things we see is if there isn't an advanced plan, that's the biggest issue. So we really look to the person who is most vested and has been providing care in a close relationship. And that's not necessarily a spouse or a child. In fact, we find many times it's exactly the opposite. And a lot of the conflict we see is when there are blended families and when there are different ones that come in. So we really try to find the person that's been most vested, closest, that would know and could really have the individual's best interest by knowing them well.
Right, so that's the person that you're going to elect, hopefully. All right, so it's time for another break. I'd like to thank our guest, Dr. Chet Gentry from Innovative Family Care in Cookeville, and Barbara Brennan, Chief Operating Officer and Chief Nursing Office of Alive Hospice. When we come back, we'll shift gears and take a closer look at what advanced care planning looks like in real life. Don't go away. See you right after the break.